Good morning, everyone. I am Dr. Kuldeep. I am Associate Professor in the Specialty of Oral and Maxillofacial Surgery at ABEX Trauma Center. And today I will be talking about GMC fracture and its management. So we will discuss a little about pertinent anatomy, classification of this fracture, clinical presentation and management part, and surgical approaches and a few cases. So zygomatic bone along with the zygomatic arch form an important component of lateral midface. And because of its prominent position, this is the most common bone to get fractured after nasal bone and constitute around 40 to 60% of all maxillofacial fractures. So the common etiology, most common etiology is road traffic accident followed by fall, assault, and sports injuries. Zygomatic bone in itself is very thick bone, but it is weak at its articulations. So the fracture line runs from anterior limit of the inferior orbital fissure superiorly, anteriorly, and inferiorly, and also to the zygomatic arch. Often we come around with different terminologies like zygomatic maxillary complex fracture or zygomatic complex fracture, tripod fracture, tetrapod fracture, and pentapod fracture. Because this bone articulates with the maxilla over a wide area, so whenever any impact occurs on any of the bone, it influences the other. So coming to the classification, different classifications have been proposed from time to time, namely Rowe and Kelly classification, Knight and North classification, Manson's classification, Rose classification, Marcus classification, and Henderson's classification. The most biodynamic classification and most commonly followed classification is Rose classification, and it is based upon the stability of the fracture after reduction and axis of rotation around the axis, namely the vertical axis and horizontal axis. So the vertical axis is an imaginary line passing through the frontozygomatic suture down to the zygomatic-maxillary buttress, and any impact which occurs medial or lateral will result in rotation around this axis. And most commonly, these fracture patterns are stable after reduction. Another horizontal axis is formed by the zygomatic arch line passing through the infraorbital ring, and any impact above or below this imaginary line will result in rotation around this axis. And these fracture patterns are relatively usually unstable after reduction and require more rigid fixation. Similarly, inferiorly, in-block displacement of zygomatic bone are also unstable after reduction and require more fixation. Now coming to the clinical presentation, these patients present clinically with some functional or aesthetic deformities. The most commonly, these patients present with trismus, which could be due to impingement of temporalis muscle because of the medially displaced arch fracture, or because of hindrance in the movement of coronary process because of posteriorly displaced zygomatic body of the zygomatic bone. And because of entrapment of muscle, extraocular muscle, these patients may also present with diplopia and involvement of infraorbital zygomaticofacial and zygomaticotemporal nerve. These patients may present with paresthesia or hyposthesia and the distribution of these nerves. These patients, aesthetic deformities, these patients are present with periorbital edema and ecchymosis, depression or flattening of the malar eminence, widening of the midface, enophthalmos and hypoglobus, antimongoloid slant, and increased scleral zone. As we can see here in this image, the lateral canthal tendon is attached to the Wittnau's tubercle, and any fracture above this attachment and inferior displacement of zygomatic bone will result in antimongoloid slant and increased scleral zone. So coming to the management part, the surgical outcome in GMC fracture will depend upon choosing the right indication for intervention and an ideal time for surgery. So the best time to intervene is as early as possible, and it results in best surgical outcome. But when the indications for the intervention are questionable, it is better to wait for edema to subside, and we then reassess the patient and determine the treatment plan. So most of the GMC fracture, which are incomplete, undisplaced, and minimally displaced, they do not require any intervention. What we advise these patients is to keep them on semi-solid diet for 3 to 6 weeks and regular follow-up to look for any sign of displacement or any functional impairment, and then we can decide whether to operate them or not. Then indication of the repair can be classified into two, the cosmetic defect and the functional defect. Cosmetic defect like any facial deformity like increasing the facial width or depression of the malar eminence, loss of lower eyelid support, and ocular dystrophy because of inophthalmos and hypoglobus. Functional defect include limitation of mouth opening and sensory nerve deficit in the distribution of infraorbital nerve and ocular movement restriction due to entrapment of extraocular muscle. Uh, One relative contraindication for intervention is only seeing eye on the affected side, and sometimes we have to postpone our treatment because of questionable neurological status and diminished vision in the opposite eye. So, what are the treatment reduction methods of the zygoma? This can be divided into indirect reduction and direct reduction. In indirect reduction, we do not surgically expose the fracture site, but and the most commonly used methods are release temporal approach, where we go the plane between the temporalis muscle and temporalis fascia. We insert our zygoma elevator and manipulate this bone in order to reduce it. And another most commonly used approach is Keen's approach, in which we give vestibular incision and we insert our zygoma elevator and reduce it. Other percutaneous approaches like release, this is Carroll Girard screw. We give a stab incision over the body of the zygoma and we insert it and manipulate it to reduce it. So whenever we do reduction, we should verify at least at 3 articulation out of the 4 articulation. Now coming to the need of fixation, and it also depends upon type of the fracture and post-reduction stability. The type, the fracture pattern which are rotated around vertical axis are usually stable after reduction, but it is always better idea to look for stability intraoperatively by applying moderate distal pressure over the malar eminence, and any displacement secondary to this maneuver will require fixation. So there are different, so the fracture patterns which are relatively stable after reduction, they require at least, 1 point or 2 point fixation, and the fracture pattern which are more displaced and comminuted, they require more amount of fixation. Now the question comes, what is the ideal sequence of fixation? So if we decided a 4-point fixation, then it is better to fix the vertical buttress first to restore the facial height, followed by fixation of the reduction and fixation of the zygomatic arch to restore the anterior posterior projection. And subsequently the infraorbital limb and GM buttress can be fixed. Now coming to the surgical approaches, again it depends upon the fracture pattern and fixation needs. So so frontozygomatic lesion can be approached via lateral eyebrow incision or upper eyelid incision, and intraoral GM buttress can be exposed via intraoral upper vestibular incision. And if the fracture is grossly comminuted, then we need to expose it through posterolateral approach like hemicoronal incision, and this can be combined with infraorbital rim, infraorbital lower eyelid incision to expose the infraorbital rim. So GMC fractures are notorious for their poor outcome, and this is because we cannot see all the articulations simultaneously. And here comes the role of intraoperative imaging in the form of CT or 3D SION, where we can visual after reduction and fixation, we get a CT done, and we can visualize all the articulation intraoperatively, and subsequently we can correct it then and there only if there is any discrepancy. For complex cases like comminuted fractures, we can opt for virtual surgical planning and computer-assisted surgery. A STL model is generated, and we can pre-bend our implants over the STL model, and we can use it intraoperatively. Similarly, intraoperative navigation can be used to determine the adequacy of reduction without exposing, without radiation exposure to the patients and operative. Now I will discuss a few cases. This 35-year old female patient reported to us with a history of trauma due to road traffic accident. As we can see, there is flattening over the left malar eminence. This is the 3D CT image of the patient showing rotation around the vertical axis and depressed fracture of the zygomatic arch. Impingement of the mouth opening was reduced because of impingement of the temporalis muscle. So we expose this fracture through upper vestibular incision to look for. This is the displaced zygomatic bone. We inserted a Haworth elevator to reduce it, and through this incision we can very directly visualize the zygomatic maxillary buttress and infraorbital ring to verify reduction at these 2 points. And the third point, we can utilize the use of this portable ultrasound. The linear transducer is placed over the zygomatic bone, and here we can see the displaced zygomatic arch bone, and this is post reduction. We can verify the reduction at this third point. And this is the immediate post-operative mouth opening. So this fracture was relatively unstable after reduction. So we fixed it at GM buttress with single plate. This is another case of a comminuted fracture. This patient reported was very late, almost around 1 month following trauma. As we can see, there is increase in the width of the midface, and there is depression over the malar eminence, anti-mongoloid slant, and increased scleral also. So this is the 3D CT scan of the patient, and we can see some complex comminuted fracture of the zygomatic bone, inferiorly displaced zygomatic arch, and fracture of the coronoid process. So we expose this fracture to hemicoronal incision, and the fracture at the frontozygomatic region, the zygomatic arch were exposed. Here we restore the vertical height first by fixing this frontozygomatic suture, then followed by we fix this zygomatic arch to achieve the anterior-posterior projection, and then the third point we fixed the infraorbital ring, 2 mini plates. So these are the post-operative results, not very good but acceptable. We can see we restored the bizygomatic width, and the facial projection is restored. Here we can see there is depression, and here good malar image. And this is the post-operative 3-week post-operative mouth opening. This is the third case which I want to include here because this patient also reported to us late, almost 2 weeks following trauma. And there was an extensive scar extending from upper eyelid to forehead to the scalp, anti-mongoloid slant, depression over the malar eminence, and increase in the zygomatic width. This is the 3D CT scan of the patient showing intact body of the zygoma, but all its articulations were comminuted. The frontozygomatic was loosely comminuted, the infraorbital ring was comminuted, the GM buttress was comminuted, and also the zygomatic arch. So for these type of fracture, we should start our reduction and fixation by reducing the side which is least comminuted. So here we change our sequence of fixation. We extended the existing laceration posteriorly in the preauricular region to expose the fracture site. We restored the anterior-posterior projection by first fixing the zygomatic arch. Then we restored and fixed the medial portion of the infraorbital ring, and then restored the vertical height of the face by fixing it at a frontozygomatic region. So this is the post-reduction CT. We can appreciate good reduction at all its articulation. This patient we treated very recently, so we do not have the post-operative clinical picture of this patient. So in conclusion, we can say that there is no hard and fast rule regarding sequence of fixation or need of fixation, and each and every case must be evaluated individually. And treatment depends upon pre-operative imaging and surgical findings. And with the application of intraoperative imaging and virtual surgical planning, better and more predictable outcomes can be obtained. Thank you, sir.